invite Professor Lopez to do the presentation on the topic New Mortality Surveillance Methods for Community Deaths. And let me briefly introduce him to all of you. Professor Allen received his PhD from the Australian National University in Canberra, and he is a Melbourne Laureate Professor and the Gordon Vice Chair of Global Health and Burden of Disease Measurement at the University of Melbourne. He is also Director of the Global Burden of Disease Group in the Melbourne School of Population and Global Health. He is an affiliate professor of Global Health at the Institute of Health Metrics and Evaluation at the University of Washington. Over to you, sir.
Gentlemen, thank you very much for the very kind invitation to talk to you this morning. We are great fans of Sri Lanka and Australia, not only your cricket team, but also the fact that education is so highly valued in this country. And it is a terrific ingredient for development, as it is you see in Western countries. So anything that we can do to support and encourage that is something we are very, very pleased to participate in. So I'm very delighted to be here today, have a chance to speak to you about research and about my research. I am now, as you can see from the colour of my hair, getting to the end of my research career. You are all starting your research careers. But research, particularly health and medical research, is absolutely fundamental to improving population health, whether it's in Sri Lanka, whether it's in Papua New Guinea, whether anywhere on the planet, including Australia. And that's been part of my obsession throughout my academic career, to drive competent research, to develop research that will be influential in changing people's lives. And I urge you all in this excellent institution that you're graduating from to keep in mind that life is not just about good clinical practice. It's about opportunities for participating in research to improve practice and the health outcomes of people that we serve. So what I'm going to talk about today is a somewhat abstract concept of research. It's my own passion about research, and that is the measurement of causes of death in population. So why am I obsessed about causes of death in population? Well, we're all involved in the health system in Australia, in Sri Lanka, anywhere in the world. We are involved as health professionals in the health system. And the goal of the health system, the fundamental goal, is keeping people in Sri Lanka, in this case, alive and in good health well into old age. And if we want to do that, how do we achieve that? Well, the best way to do that is to have health policies and services aligned with strategies to prevent premature death. You can't talk about health systems preventing disability if people are not alive in the first place. So keeping people alive well into old age is absolutely fundamental. And the information that government requires to keep people alive is accurate and timely mortality data on the age, sex, and especially the cause of every death in the country. 120,000 people a year die in Sri Lanka, about the same as in Australia. Do we know reliably what those people died of, particularly those who die by what we call premature death or avoidable death? Can we understand what they died from so that public policy in this country can be better focused on preventing those deaths? That's what the fundamental question is. And so knowing what people die from is the first step in being able to prevent others from dying from the same thing if we have enlightened public policy. So how do we get this essential mortality information in Sri Lanka on causes of death? Well, the ideal is something that you've got almost working here, a well-functioning civil registration system where the cause of every death is certified by a medical practitioner, not by a nurse, not by an allied health worker, but by someone who is trained in medical school to complete the death certificate, the international form of the death certificate issued by WHO. Now, that's the ideal, but the reality in many countries, including Sri Lanka, is that 50% of your deaths occur at home, and they do not have any medical facility, any diagnostic capability, and they have therefore no medically certified cause. Not only the cause of these deaths, but 50% of the deaths in Sri Lanka means that health planning in this country is not going to be evidence-based. Professor Dr. Margaret Chan, Director General of the World Health Organization, understood this. She understood the importance that every country in this planet must have reliable information on who dies of what to guide health policy. She said, without these fundamental data, that is counting births and deaths and reliably recording the cause of death, we're working in the dark. We may also be shooting in the dark. Without these data, we have no reliable way of knowing whether health interventions are working or not. So what's the solution? If that's what we need, the ideal is a long-term strategic prioritised investment in strengthening civil registration and medical certification systems. That was what all countries should aim for, and indeed that's what Sri Lanka is aiming for. But that's the solution, the ideal. The reality is that decision makers in Sri Lanka today will need to make critical decisions about preventive health policies based on currently available information. And that information is often very poor quality data. So we need worldwide to come up with an interim solution pending the development of a vital registration system. This solution must be cost effective, must yield rapid data, and must be applicable in rural, remote and underserved populations, and it must yield accurate and timely information. Now, the only way that we can do that in global epidemiology is through a technique called global autopsy. And so what is global autopsy? So it's an interview of the deceased family using a standard brief questionnaire to gather information on signs and symptoms experienced before death. The second part is we have to diagnose that information to get the cause of death. There's no medical doctor involved, there's no clinical services in many populations. How do we get the cause of death of people who die? And this is why we use global autopsy. Historically, the interviews have been reviewed by a doctor, but this approach suffers from many disadvantages. It's expensive, it's time-consuming, it's non-standardized because doctors in different countries are trained differently and they'll interpret questionnaires on signs and symptoms differently, and hence they'll come up with a different cause of death for the same case. In other words, it's not standardized. But perhaps more important is the moral argument that asking doctors to review global autopsy questionnaires takes them away from the essential healthcare provision we expect from them. So these are all problems, and as a result, the interrelatability of doctors, that you can give the same form to different doctors, you're likely to get different responses about the cause of death. So are there alternatives to physician review? And the answer is yes. Now, recent block of research that I've been involved in with colleagues looked at different computer methods and compared them with physician review using the same questionnaires. And these analyses revealed that computer methods were more accurate. Let me repeat that. Computer methods were more accurate than doctors, and one method in particular, the tariff method, was better than all others in diagnosing the cause of death. And here's the results that show that right here are various methods, InterDNA, KL, Kingham, tariff, and doctors. We gave all these methods the same questionnaires, and here's the results. The new truth. That tariff method was 13% more reliable than doctors. 13% more reliable than doctors in certifying the cause of death. It's cheap, it's computer algorithm, it's costless, and it's reliable. And when we gave that doctors in hospitals, in big Mexican hospitals in Mexico and a couple of other countries, they were not that better than these computer algorithms. They were 90% more. These are doctors in hospitals getting the cause of death right. These are doctors in the field looking at the verbal autopsy. So this was an important finding. Now, so what is this tariff method? What is this method that actually performs better than doctors in diagnosing the cause of death? So it's based on what's called the signal-to-noise concept. The questionnaire items get a score according to the number of times that symptom was endorsed by the respondent. In other words, the respondent answered yes. The respondents are normally the mothers or fathers of children who died in the family, or brothers or sisters, or children of parents who died. So when a respondent answers yes to a question about the presence of a symptom during the interview, so did the decedent have yellowish eyes, yes or no, and that's called endorsing. And then any symptom reported in the verbal autopsy that's highly predictive of a particular cause is what we call the signal. And this will have a significantly higher tariff score for that particular cause compared to other symptoms. So you can imagine a cause like lung cancer. Well, there are certain symptoms that we ask in the VA that will be more strongly connected with lung cancer than they will be with heart disease, for example, or measles, or some other cause of death. And it's the cause that claims the highest score from the symptom pattern that we call the tariff method. And here's a very simple example of what I'm talking about with this example, with this method. Let's just take three causes: AIDS, malaria, and falls. And then we ask, imagine we only asked four symptoms. Did the decedent suffer a fall? Was he or she diagnosed with TB? Did he or she have fever before they died? And were they diagnosed with dementia? From our research, this is the tariff scores. The higher the score, the higher that symptom is with the cause of death. So when the family said the person suffered a fall, the true cause of death was likely to be a fall. If a person was diagnosed with TB, they had a much higher tariff score for AIDS than they did for malaria, falls, and so on. So if we take an example of an interview with a family, and we asked them, and they said, no, the person, my loved one, didn't suffer a fall. Yes, they were diagnosed with TB. Yes, they had a fever. No, they were not diagnosed with dementia. And we multiply those 0, 1 vectors by this tariff matrix, we get the following scoring system. So for each of these causes, AIDS gets a score of 6, malaria 1.4, and falls actually gets a negative tariff. These are the tariff scores for the person with that questionnaire. So since AIDS has the highest of these tariff scores, when the person gives these responses to the symptoms, we conclude that the cause of death is HIV or AIDS. So the problem then comes is, well, if we're in the field and we have this method of asking families, how can we make that most efficient? How can we encourage families to respond to a questionnaire about the death of their loved one in order for us to generate essential public health information for all health services to do better lives? So we've done item reduction theory in our research. The original questionnaire we started off with was about 200 questions. We progressively reduced the items, and this is the fall-off in the performance of the verbal autopsy instrument. So you can see we can cut the number of questions from about 200 to 90, and we only have a very small fall in performance. Once we cut the questions beyond that, performance falls off very quickly. That's for adults, and this is for children. We can cut the number of questions from 120 to 60, and we did not lose anything in performance. It's only beyond then that performance starts to fall very quickly. So in other words, we have a short-form questionnaire, only takes about 20 minutes. We have an automated diagnostic method. We put those together and we come up with a tool called Smart VA. And what I'm here in Sri Lanka for is talking to the Ministry of Health and the Registrar General under a new funded initiative called the Bloomberg Data for Health Initiative, where we're proposing to use this Smart VA in order to improve the cause of death quality for the 50% of Sri Lankans who die outside of hospital without a medical certificate. There are a number of advantages I went down through for using VA. But you can use it on a tablet. You can go to a family and you can use this. You've all got these. I stand there and I respond, get the responses from the family in 20 minutes on this tablet, on this iPhone, or if you want, you can use a tablet. We've got them in different languages. And what I then do is take those responses, and at night, the same day, I can do 20, 30, 40 of these in a day, depending on how efficient we are. I take them all and I upload them onto a spreadsheet with the tariff algorithm with colleagues from Institute of Health Metrics and Evaluation in Washington. We simply press the start button and out comes a spreadsheet with the probable causes of death for all those interviews that I did that day on a smartphone. It's as simple as that. And this will greatly change the quality of information for populations. Here's an example from Vietnam. I've done some research in Vietnam where there's nothing known about causes of death. We applied Smart VA on a sample of 500, random sample of 500 deaths that were given to us by the Ministry of Health. And here's the fraction of deaths in Vietnam, this is in rural Vietnam, from different causes. And this looks reasonable to me. 16-18% of deaths from stroke, another 14% from traffic accidents. Major cause of death not only in Sri Lanka, but also in Vietnam. Ischemic heart disease, diabetes, you can see minor homicide, TB. These are the fractions of deaths. This is a reasonably accurate picture in my view. There are some things that are a bit strange. For example, I was surprised by the fraction of deaths, about 3% from diarrhea and dysentery. That it might be true. But nevertheless, from having no information in Vietnam to plan health services in rural areas, I now have cheaply and I believe cost effectively information using Smart VA for verbal autopsy. And here's some research I did in Thailand. It's a little dated now, but I'm sure the results are the same. The Thai government is very successful in measuring mortality and capturing the fact and registering the fact of death, as you are in Sri Lanka. But 50% of the Thai causes of death are assigned to something called ill-defined causes. Now, if you're a medical practitioner, you're in government, you're planning health services for the Sri Lanka or Thai population, having a diagnosis of ill-defined, don't know, is completely useless providing public policy. You need to do something about it. So Wellington did a verbal autopsy study on a random sample of 1,500 ill-defined deaths, and this is what we found. So instead of all these ill-defined deaths in Thailand, 16% were actually stroke, 11% chronic obstructive lung disease, 8% ischemic heart disease, 5% diabetes, and so on. In other words, we can get a much better handle on causes of death in rural populations by using verbal autopsy. So I've just tried to present to you the results of some research I've been involved in over the years on burden of disease and measuring causes of death in population. Why am I obsessed about causes of death in population? Because it's the essential health information that governments need to keep people alive into old age. If they don't have that information, they don't know whether traffic accidents are a big cause of death, yes or no. Is measles still important? Is lung cancer arising? They cannot answer any of those policy relevant questions. In conclusion, registering deaths without accurately capturing cause of death is of limited value for public policy. Think of what you're doing in Sri Lanka. How valuable are all those billions of rupees you spend every year for public policy if you're not accurately capturing causes of death? When deaths are not medically certified or there are no medical records, for example, dead on arrival, the use of verbal autopsy is the only viable way to obtain causes of death for planning. Recent advances in information technology and research have led to diagnostic platforms and short forms that are quick, reliable, cost-effective and cheap, and are also open source to apply, and are more accurate in studies that we've done than physicians in diagnosing the cause of death. You can talk more in discussion why that might be. And my recommendation in countries like Sri Lanka is the application of this tool called Smart VA or the vital registration system will greatly increase knowledge about who dies of developing populations where medical certification of death is currently not possible. extraordinary juxtaposition of IT and research advances that can materially change the evidence base in this country for proper health planning. Thank you very much.
Thank you, sir. I kindly invite Professor Allen, Dr. Nihal to be part of the panel of judges for session 1.